kind of talk.
Hello, Dr. Ferrara.
Yes.
Hello.
Thank you for your question. So the audience is basically undergraduate students, but also the experience. So the main experience are students. Basically.
Great, 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 great.
Thank you for that.
Okay, great. So it's a pleasure to talk to you. My name is Napoleon Ferrara, I'm present professor at UC San Diego, University of California, San Diego. Actually, I'm a native of Italy. Actually, my background show some of my native country, like the city of Florence. I'm not from Florence, but this is a beautiful city. And I know never been in Kazakhstan, and I read lots of things about your beautiful, very interesting and fascinating country. So I'm very happy to share you a little bit of my story. I've been working in this field now for many, many years, actually. I came from Italy in 1983. And I did a fellowship at the University of California, San Francisco. And that's where my career started, my work on angiogenesis began, And so let me tell you what really angiogenesis is a very fundamental physiological process. It means the growth of blood vessels. And the blood vessels, of course, are indispensable for life because they bring, nutrients, they bring oxygen to the growing tissue. So it will be very difficult to conceive, a multicellular organism without blood vessels. It's been traditionally divided, classified in angiogenesis, which is the most common form of blood vessel growth in the adult. There is de novo formation of a capillary from a venule. And arteriogenesis, which is actually the growth of arteries in response to a variety of circumstances. And then there is a third process, which is called vasculogenesis, which is more of an embryonic phenomenon, which is the in situ differentiation of endothelial cells from the mesenchymal cells. It is clearly primarily an embryonic process. And once again, most of the time, what you have in angiogenesis is actually with this kind of process, which started with sprouting from local venule, and there is growth, of blood vessels. So clearly it's a fundamental physiological process. But what has been very interesting to many people is the possibility that angiogenesis plays a role in diseases. That's most notably in cancer. This is actually not very old hypothesis. This is from a paper published in 1939. This is a seminal study because this investigator used a transparent chamber, put implant in the rabbit here. So they implanted a tumor, which is the structure here. And then they note, that after a few days, there is this growth of blood vessels, which grow toward, the tumor in a radial growth of blood vessels. And this early investigator speculated that the tumor must be producing what they call a blood vessel growth, stimulating factor. In other words, an angiogenic factor. At the time in the 30s, even though this was a clearly very fascinating hypothesis, the tools, to advance, this field that did not exist. We need to wait, decades until the biochemical and molecular tools became available. And clearly work which was very influential in generating this idea was the work by Dr. Judah Folkman, who in 1971 clearly communicated very effective with this old idea, this old hypothesis. And essentially was the first one to suggest, the blocking angiogenesis could have a therapeutic implication, could be something worth, exploring. And this was the general concept, at least angiogenesis in cancer, the idea that, a carcinoma inside, start, growing but cannot grow beyond a certain size until the tumor becomes vascularized. It is a different stage of this actually progression. The vessel growing, the tumor expanded, then expand in a very dramatic way. It is a theoretic what happens if you block, angiogenesis with an antagonist. The tumor is expected, to be smaller in size. So this was a seminal idea, and in the 80s, the search for this angiogenic factor began to try to isolate, this factor. When I started working in this field, which was essentially already in the mid 80s or so, already there was a long list of angiogenic factors. This is only a partial list, acidic and basic fibroblast, growth factor, epidermal growth factor, and many others. But there was a fundamental problem with this work. None of these factors, even though they were potently could induce angiogenesis in some, bioassay, like in the chick, choriolantoic membrane, or in others. When you try to block, this factor in a tumor model, nothing happened. This was the confusing aspect, the frustration at that time, It is this very insightful quote, by Clarksbrun and colleague. It points that even though there are many angiogenic factors, it's the distribution in action is not yet known. So it's very difficult to speculate whether they contributed to angiogenesis. This was actually the status of the field at that time. And I was very fortunate, excuse me, to isolate, in the late 80s, actually, this work started when I was a postdoc at at University of California in San Francisco, and I continued this work actually in a biotechnology company called Genentech, which has become very famous place. We're able to isolate, a factor which today is believed to be a key regulator of blood vessel growth, which is called vascular endothelial growth factor. Without going into much detail, this is the sequence of the bovine and human VEGF. We clone first, the bovine and then the human. And there is a very high level of homology between the very highly conserved homology. There is over 90% identity between. So this suggests that this could be an important molecule. And now this is some of the characteristic of this protein, which is a mitogen for endothelial cells, can induce permeability, is a chemotactic, and it's a protein with a molecular weight approximately 45 kilodalton. Of all experiments that I could show you to illustrate, the importance of VEGF in developing, I don't think I can really do any better than this study, which was published already in 1996, so 26 years ago. And this is the knockout, the gene knockout of a VEGF in the mouse. This is the wild type, mouse with both allele of VEGF. This is the yolk sac of embryos at day 10.5, like a mid-gestation. And this is instead, the mutant which lacks only one of the two VEGF alleles. As you can see, there is a lack of blood vessels in the yolk sac, and there is actually the embryo is already severely underdeveloped, it's already dead. This is it's a very striking result, because at that time it was the first example of embryonic lethality after inactivation of only one copy of a gene. Usually you need to activate, both copies to have this effect. And this was very remarkable. It still is, even today, is one of the very few examples of this critical requirement for a single gene. This was in 1996 or in 1989. So now we have a much better understanding of a VEGF, how VEGF, function is VEGF now is known as VEGF-A. But there is other member of the family like VEGF, B and placenta growth factor, or VEGF-C and D. They interact primarily, VEGF-A interact with the tyrosine kinase receptor, which is called VEGF receptor 2, which is the key mediator of the biological effect of VEGF, angiogenesis and mitogenesis. And there is another receptor which is called VEGF receptor 1, which is actually was the first receptor to be identified, which is not a major signaling receptor, but bind the VEGF with a very high affinity, and this can regulate the bioavailability to VEGF receptor 2. And there is a third receptor called VEGF receptor 2, which is mostly implicated in lymphatic angiogenesis. So the interesting aspect of this family of molecules is that they regulate both the blood and lymph angiogenesis, which is, and there is a very strong genetic evidence in support of that. But this, of course, it does not mean to imply that VEGF, in its receptor, the only system which result, regulating vasculogenesis and angiogenesis. This slide, illustrating the fact that there is a multiple molecular and cellular players. And there is a kind of a sequential activation of a number of receptors. This is like a symphony, which is very tightly regulated. In the hemangioblast is thought to be a primordial cells. FLIC1 is actually the murine variant of VEGF receptor 2, which is critical for differentiation and expansion of the cells, of the angioblast. in response to some signaling molecule like a notch. There is also differentiation and then you have a specification of arteries and veins, which are regulated by another family of factors, which is called ephrins, which are another tyrosine kinase receptor. And that we have a correct assembly of the vessel wall, which included the so-called pericyte or mural cells. You need also the involvement of the PDGF, PDGF-V, PDGF receptor. So it's very complex, system, which is required, to have, this correct, vasculature, which otherwise would be very defective. And there is a number of genetic mutation which affect, all this, affect all of the above. Then, but let's go back to the role of VEGF in tumor angiogenesis, which was one of the initial questions. We know that there is a variety of events that can regulate, VEGF in the tumor environment. For example, hypoxia is a key regulator, but not the only one. There is also a number of cytokines like PDGF, IGF-1, etc., which can upregulate, VEGF. And also very important, the VEGF gene can be regulated by oncogenes, like, for example, RAS, and this all results in the release of VEGF, in the tumor microenvironment, which at this point is able to activate, VEGF receptor 2 and regulate a result in angiogenesis. And so this was the hypothesis at the time. This actually was probably the very first experiment which actually tested this hypothesis. This paper was published in 1993 by our group, at Genentech. We developed a monoclonal antibody which regulate, which block, VEGF. At the time, I want to emphasize that there was no direct evidence that blocking angiogenesis blocked tumor growth. It was widely believed that you need to block, many factors to inhibit angiogenesis, not just one. You need to block maybe a dozen of factors, and no one has succeeded doing that. So at the time, we were very, very surprised that blocking only VEGF with this monoclonal antibody, which is called A461. This is a term to keep in mind for what I'm going to tell you next. Could have a very profound inhibitory effect on multiple tumor cell lines. This is a rhabdomyosarcoma, which is a tumor of the skeletal origin. This is a glioblastoma, which is also a very aggressive tumor. And this is another kind of a tumor. And all could be significantly inhibited by this monotherapy. And this is actually in intramitral microscopy experiment we did actually with a collaborator a long time ago. Essentially, it's a way to image the vasculature of the tumor, actually. And you can see that, this is happened to be one of a rhabdomyosarcoma, which at different time point, you see that there is an extensive growth of blood vessels, which become tortuous, become very disorganized. And that is after treatment, in response to treatment with this anti-VEGF antibody. You can see that the angiogenesis has been substantially inhibited, substantially blocked, and clearly show that this is an anti-angiogenic effect. At the time, we were very interested in going to the clinic. You cannot go to the clinic to treat humans with the mouse, with the murine antibody, because it could have a strong immunogenic effect. The human immune system would recognize the antibody as a foreign, and they could be eliminated. So you need to know at that point that there was an important technology which was very helpful, which is the humanization of an antibody. I'm not going to go in this detail because it's very technical, but if anybody has any question, essentially it consists, in introducing in a human antibody the so-called complementary determined region, the regions from the mouse antibody which is responsible for binding antigen, such that in then your humanized antibody, this is actually in blue, you have the human antibody. In red are the murine sequence, which has been engrafted in this human antibody. So essentially, the antibody is substantially actually human, maybe 95% human, only a few sequence, of mouse origin. And this is a very important technology which allow you to go to the clinic, and this is what we did. And the antibody we generated by this process is called bevacizumab or Avastin, which was the first, anti-angiogenic antibody to be approved for therapy. And this antibody actually, once again, is mostly human and replicated the same characteristic at the murine antibody. And this was the first study that proved the hypothesis that blocking angiogenesis had benefit in humans. This was an old study published in 2004, actually, the result in the first approval of this therapy in patients with a colorectal cancer. There was a survival benefit. There was a survival benefit, a mean survival benefit of about 4 to 5 months. It may not seem a lot, but in reality, oncological therapy is extremely disappointing. The measure, the efficacy in solid tumor is measured in months and not in years. So there is much more that needs to be done. But was clearly this was the first, the first attempt, and clearly there is room for improvement. This is another tumor which was responsible to anti-VEGF therapy, which is actually ovarian cancer. And this after surgery, patients were treated with the chemotherapy or with an antibody with VEGF, which was continued. There is a very significant improvement in progression-free survival. Actually, this anti-VEGF antibody called Avastin is this is a slide from 2019. Still is one of the most widely used cancer therapeutics. Actually, in 2019, it was the drug number 5. Not only an oncological product, but all drugs. So this turned out to be a very widely used therapy for cancer, even though clearly there is room for improvement. And of course, bevacizumab is not the only VEGF inhibitor, but there is many others. Actually, this is a very long slide, etc. And I'm not going to go in the interest of time. I would like to point out that in addition to VEGF, there is other potential target in the vasculature. In theory, if you could combine a drug which inhibits, let's say, VEGF with a drug which inhibits, another component, you could have potentially have an additive effect. This is a diagram of the tumor vasculature. You have a series of targets like other receptor, like a Tie2, and then PDGF, which is expressed in pericyte, this mural cells, as well as some integrins. And unfortunately, I can say, to make a very long story short, this approach was not particularly successful. None of this additional antibody, additional inhibitor increased the benefit of anti-VEGF. This is still one of the things that really confound us. And so the question is how to improve, the efficacy of this agent. This is, we thought, the tumor microenvironment, the innate immunity could be a way to actually increase this activity. This is illustrating, the complexity of the tumor microenvironment, where you have not only this is the tumor endothelium, you have these are the tumor cells, and you have a complex interplay between the tumor and the bone marrow. There is homing of cells, and so this is probably a place where actually you could interact. We focused a number of years ago, on some cells, called myeloid cells, which are called CD11 myeloid cells. One of the subset of the cells, is called myeloid-derived suppressor cells, which those who study immunology they are thought to be very important cells because they can regulate, immune function. And so we believe that, there is other players in the innate immunity which can contribute, to activity of anti-VEGF, some the factor produced by neutrophils, which seems to be a major player in resistance to VEGF. However, what it turned out to be over the last several years of even greater importance than innate immunity has been adaptive immune system. I'm sure that many people are familiar with the concept, the immunotherapy and combination with the immune checkpoint inhibitor. We can essentially unleash the immune system, and this approach has been successful even to some degree. Not all patients respond to immunotherapy, but there is a subset of patients which have a very prolonged response. And VEGF has been reported to have effect in the skin. For example, it has been shown that if you block VEGF, there is infiltration of the lymphocyte in the tumor microenvironment. This is, for example, in patients with melanoma, treated with bevacizumab with anti-VEGF antibody. As you can see, there is significant infiltration of the lymphocyte in the tumor microenvironment. This is explained in additivity between this agent. There has been actually clinical trial already FDA approval of this treatment. For example, this is the combination of an antibody called, which is an anti-PD-L1 antibody, which is an immunotherapy antibody, in combination with the bevacizumab in lung cancer. There was a significant benefit. But what's probably is even more striking, actually, this is an approval very recent, only 2 years ago. Combination of this anti-PD-L1 antibody with the bevacizumab in liver cancer, in unresectable liver cancer, which is it's been a very intractable disease. And this treatment is expanding, is actually is advancing the therapy, the efficacy of this treatment to liver cancer. It is now extensive research to try to improve, cancer therapy in combination with the VEGF inhibitor with immunotherapy. But there is clearly another set of disease which turned out to be also very important target, of anti-angiogenesis. If anything, there is even more important than cancer. It is Samite disease. The slide illustrates, the normal rate. You can see there's a very nice vascular pattern. It is actually the rating of a patient with the proliferative diabetic retinopathy. You can see there is lots of proliferation, lots of blood vessels which look very tortuous. Actually, they resemble tumor vessels, and there is lots of bleeding, lots of hemorrhage, and a patient in this condition could become blind because of this. All this bleeding can organize into a clot, which resulted in detachment of the retina and blindness, which is, of course, it was one of the most, dreadful things. It is some concept of vascular biology which explain actually what happened in this condition in the diabetic retinopathy. There is a loss of these cells that I was alluding at the beginning of my talk, which is the pericyte, which are called mural cells. And the loss of pericyte results in this formation of this microaneurysm. In other words, the vessel wall becomes much weaker. And so essentially there is this extravasation of the vessel wall, and this microaneurysm can burst and result in bleeding. Also, it can result in formation of a clot, which result in hypoxia, in ischemia, which result in further ischemia and perpetuate, this vicious, cycle. Study we published, actually, this is very old, study, but the study clearly stood the test of time, led, to a therapy. In the study published with some collaborator at Harvard in 1994, my God, almost 30 years ago, we were able to measure for the first time the levels of VEGF in the eye fluid of patients with the diabetic retinopathy and other retinal diseases. And we found that there was a very striking correlation between the level of VEGF, for example, in active proliferative diabetic retinopathy, and compared to control, there is a very dramatic increase in the level of VEGF. It was very interesting when the disease became quiescent, the level of VEGF, dramatically went down. And this is another ischemic retinal disease, which once again gives something very similar, very high level of VEGF. But the study, although very provocative, were a purely correlative study, purely and clearly you need an animal model into it, at least to reassure yourself that this idea is real. In the study, we're able to actually, this is a monkey model of ischemic retinal disease, consisting occluding with the lesser retinal veins, which result in ischemia. You see this iris, which is full of blood vessels, the extensive angiogenesis in the iris. And this is actually monkey eyes treated with an anti-VEGF antibody, which is the same antibody we use in the tumor model. In this case, fortunately, the human and mouse VEGF are identical at the protein level. And this is, as you can see, was almost a complete inhibition of the neovascularization. Of course, from going to the animal to the clinic, there is a very huge, jump, But this actually illustrates, some of the disease, actually the vision of patient with some of this vascular disease. This once again ideal normal vision. This is the vision of a patient with the diabetic retinopathy. You can see there is a very blind spot, in the periphery, but the central vision is somewhat, preserved, and instead, this is another major disease, which is age-related macular degeneration, which is clearly is the leading cause of blindness in the elderly population. Actually, I'm going to spend a minute into that, illustrate, really the macular degeneration, which once again is a very complex disease. Is classified in early AMD, intermediate, advanced, and non-neovascular AMD, and finally advanced neovascular AMD. There is a very strong genetic component in that. There is actually some gene mutation which result in inflammation. Inflammation seems to be a very crucial event, and the most advanced stage is the neovascular stage, which is even though account for about 20% of the case of AMD, result in about 80% of the vision loss. So this is a very destructive event. Another event, another condition which is can result in vision loss is called geographic atrophy. There is this large area of the retina which undergo atrophy. And this is still an unmet medical need. There is no effective therapy for that. But instead, we're very fortunate with the anti-VEGF therapy. It had a very substantial benefit in patients with the neovascular AMD, with this form AMD, with there is a lot of blood vessels. It is a study which actually we use an antibody fragment called ranibizumab, which is based on the same antibody we developed. It is a patient with the advanced, macular degeneration. And this is the vision this is a chart, in the vision measure in a chart, This in green is not an inert, control, but this was what at that time was the standard of care, which is a photodynamic therapy. You can see there is a very initially modest increase in visual acuity, and there is a vision loss, which essentially overlap with the no treatment. And this instead was with two doses of this antibody called ranibizumab, this anti-VEGF antibody, 0.3 or 0.5 milligrams. In this early clinical trial, it was administered on a monthly basis. And as you can see, there was a very, at that time, totally unexpected. There is an increase in the visual acuity of patient, which lasts, for 24 months, the duration of the trial. This was totally unexpected. This seems to be some events that take place, in some cell biology event you can explain this benefit. Once again, there is loss of a pericyte in these vessels. There is a structural abnormalities, and in response to VEGF, there is this growth of this. This choroidal neovascularization. This is without any treatment, and instead with the anti-VEGF treatment, there is a very significant inhibition. There is a very substantial inhibition. There is also regression of vessels, which actually seems to be abnormally, which we can be somewhat normalized. And we know there is actually benefits. Some population study actually have showed that show the benefit of this treatment in a popular. This is a study conducted in Denmark, which is a small country which have a very good health care system. Everybody receive medical care, and the state is a single payer, so it's very different from the United States, for example. And this is the plot, the legal blindness due in this lower curve to causes unrelated to AMD, and this is instead due to AMD, to macular degeneration. As you can see, after 2006, when the anti-VEGF agent were introduced, there has been about 50% drop drop in the incidence rate of legal blindness, show that this is clearly an effective treatment, and this has been seen in other countries. It is now the long-term, actually benefit from this treatment. For example, this is the illustrated 5-year outcome with anti-VEGF, treatment. 50% of patients, have a good after 5 years have good vision, and about 10% have a perfect, vision actually. And this result, according to this paper, would have been inconceivable before this agent were available. So this has been clearly a success of a personalized medicine or target therapy in this population. Actually, what is very unfortunate is that treatment with other agents, just to mirror the cancer situation, the combination with other therapies so far and not to receive, and not to increase the benefit of anti-VEGF therapy. But at least in this case, the benefit is very strong. Actually, the slides illustrate, the point, this is that, you need, to have, to have the greatest benefit of this therapy. You need to have a very good, health, system, such that patients are followed up and have been treated. This is a real life experience outside the clinical trial in different European countries. It showed that, in the best result was seen in the UK, where patients were seen more frequently, they receive more injection. But actually, in the first year, the patient received an average 5 injections. And on the second year, they receive only 2.5 injections. You can see there is a drop, in visual acuity. In other countries, the results were worse because the patient was seen less, frequently, etc. And so this study made a very important point, that you need to, it would be ideal to give a slow release, way to deliver the drug, And actually, there has been many attempts, but what I think is probably so far the most successful is a device developed, actually co-developed by Genentech and Roche, which is a port delivery system. It's inconvenient because it consists in a surgery, so you have to implant a device in the vitreous. But you can refill the device. And this device, you can release ranibizumab in a steady state way. And there is at least, for 6 months. So there is a preliminary, this has been just approved for therapy in the United States. And there is a clearly evidence that, this result in the probably optimal treatment, and a subset of patients do not need any therapy after, there seems to be a disease modification effect, So this is what the state of art of this field, We hope that, there is still, after 15 years, still VEGF is remained the main therapy. But we certainly hope that actually there will be other treatment coming in the horizon. And there is actually many hope that, we can treat, the dry form, the geographic atrophy, which is a non-neovascular disease, which is an inflammatory disease. There is many approaches, ongoing, but I would like to conclude, saying that I hope I give you an overview of angiogenesis. What is the impact of angiogenesis? We had the block, angiogenesis mostly with the VEGF. I'm sorry that I have to limit, to VEGF, because then is the only approach that has been clinically validated. VEGF inhibitor represent the standard of care in multiple malignancy. But there are some dramatic benefits, especially in patients with intravascular diseases like wet AMD and retinal vein occlusion, not only with the multiple VEGF inhibitor, but there is many challenges. For example, identify some biomarkers. What has been really a frustration with this field is there is not yet a validating biomarker. Perhaps a drug which, because there is no mutation, and it's been very difficult to identify a biomarker. Still establish optimal combination. As you can see in cancer now, there is some very good combination, some extremely effective combination between anti-VEGF agent and immunotherapy. In the eyes, still, we don't know if there is going to be any combination. The ones who've been tried has not been successful. And there is still lots of basic science to do in trying to understand the mechanism of resistance. And certainly will be very important, as I said before, to be able to find, a way to treat, the non-neovascular form of this disease. This is what I have to say. I hope, I'll be very happy. Thank you for your attention. I'll be very happy, to answer any question. I try to leave a little bit of the time, for questions if there is any.
Hello, everyone. My name is Gunela Ayubova. I'm greeting you from Baku studio. Welcome everyone to next series of Nobel Fest lecture series. And for who joined late, I would like to once more introduce you. It's a great honor for me to introduce a great scientist, Napoleone Ferrara. He is a distinguished professor of pathology and associate professor of ophthalmology and pharmacology in University of California at San Diego School of Medicine. Napoleone Ferrara, he is winner of Breakthrough Award in 2013 in medicine, and besides this, he has received a lot of spectacular awards, including Lasker Award in 2010 and Science of Oncology Award in 2007. Dr. Napoleone Ferrara is best known for discovery of VEGF, vascular endothelial growth factor, and his research has always been a cutting edge at the vascular angiogenesis and introduction, discovery of its regulators. So, Professor, thank you for very interesting and fascinating lecture.
Thank you very much.
Thank you for being with us today. It's our great pleasure to see you, to talk with you. And I would like to ask some questions. We have here some questions to ask.
Please.
Yeah. So as we know, your research was focused on VEGF as a key regulator of angiogenesis in normal and in pathological conditions. Did you study the effect of VEGF, anti-VEGF drugs on the, for example, on pericytes as other components of vascular wall? Are there any other growth factors which influence on pericytes and which have effect on the promoting angiogenesis?
No, that's a very important question, actually. Pericytes are very critical cells, in the vasculature. Actually, there is a very elegant work, actually seminal work done by different groups, show that PDGF-B and PDGF receptor beta are key regulator of pericyte, recruitment. Actually, some very elegant studies, and other factors like angiopoietins have been implicated, in the recruitment of pericytes. So this is a kind of event that happening in a number of diseases. Loss of pericyte characterized not only the eye disease like the diabetic retinopathy, macular degeneration, but even in tumors, there is a loss of pericytes, which facilitate metastasis. And so this is what one of the things that we learned over the years. Some people thought that blocking pericyte was a good strategy, to make it to regress the vascular. But to not be, if you block pericyte, you can promote metastasis. It can exacerbate it. So pericyte are very critical cells in the microvasculature.
Thank you a lot. Professor, can you, when I was listening to your lecture, you mentioned the VEGF-A allele, its effect on embryo and on embryo survival, and you told that the elimination of that allele leads to death of embryos. Have you studied other alleles of VEGF on embryos? Do they have the same effect as VEGF-A?
That's a great question. Actually, you must know the field very well. Well, actually, there is a family of VEGF, family member. I was very briefly a PLGF, VEGF, B, and then VEGF, C and D. As things turn out, the PLGF, does not have any major consequence on embryonic development. The same as the VEGF, there are some subtle effects, let's say in the heart, development, nothing as little VEGF. The only molecule which seems to be also very important is VEGF-C, which is a regulated, mostly lymphangiogenesis, but some early stage also regulate, the development of veins, some of the vascular system. So VEGF-C also a very important component of the system of this involved, in vasculogenesis and angiogenesis. So these are the two most important members, VEGF-A and VEGF-C. It does not mean that these other molecules are not important, just they're not so important during embryonic development. They could have other roles in adult life, and in pathological conditions.
Thank you. You introduced very great antibodies. These are anti-VEGF drugs. These are blockbuster drugs, actually, that you mentioned today. That is Avastin for treatment of cancer and Lucentin for treatment of age-related macular degeneration. Have you studied, or have these drugs have effect on the CNS disorders, the central nervous system disorders, maybe neovascular, neoplasmic disorders? Have these drugs have effect on those pathologies, disorders?
Well, they've, actually, Avastin has been approved, is one of its approval is in glioblastoma, in one of the brain cancer. There is not, this is a terrible disease. There is no effective treatment, Avastin is a modest effect, a small effect, in glioblastoma. But there is an increase in progression-free survival, but that led, to FDA approval. Unfortunately, the glioblastoma has been a graveyard, not only of the patients, but also of the drugs. All the most promising drugs have failed. So anti-VEGF has some effect. I wish it would be a greater effect, but that's what the data show. There is a certainly much better effect in other settings, but this is what we know. At least there is some level of benefit.
Yeah, thank you so much, Professor. Actually, I am neuroscientist, and that's why it was interesting for me to know the effect of these fascinating drugs on the CNS disorders. Yeah, thank you. You was talking about the interaction of immune system cells with anti-VEGF drugs, inhibitors. And you mentioned CD11B cells, then epherin receptors. And I would like to know if there are interactions between anti-VEGF drugs and the immune system, for example, cells of innate immune system and adaptive immune system. Are there any differences in these interactions between these two regulators of the immune system, the innate or adaptive?
Well, I think there is a very complex for example, VEGF is produced by the cells. It's produced by neutrophils, by macrophage, all these cells are a major source of VEGF, Actually, VEGF could be a chemoattractant, especially for macrophage, There is actually, it seems to be mediated by one of the VEGF receptor 1. How important this effect are, it's not very clear. They're very major effect, but certainly there is some biological effect, VEGF inducing homing of a macrophage, and what is probably more significant is the production of VEGF by these innate immune cells. But what the people today are very fascinated is the relation between the adaptive immune system and VEGF, There is lots of hypotheses. For example, it's known that VEGF can inhibit, the dendritic cells differentiation. It can have a direct effect in some in cells, in some regulatory cells. But what it seems to be very clear that if you block, VEGF in a tumor, there is actually increased homing of a lymphocyte in the tumor microenvironment. This has been shown in animal models, but it's been shown also in tumors. I will show you an example, like in my talk of a melanoma. treating with Avastin, with there is OMI. And this seems to is one of the mechanisms that perhaps facilitate immunotherapy. It's not inconceivable that if you block VEGF, you have endothelial cell damage, which in turn result in tumor cell damage, which could result in chemokines and cytokines, which can further increase the homing of immune cells, and facilitate immunotherapy. This is still a very active area, very evolving area. There is a clinical data, probably there is more known about the clinical data than actually biological data.
Thank you so much. Professor, the lucentin is a very important drug for the treatment of age-related macular degeneration, not just this one, but also other intraocular neovascular disorders. And you mentioned that it also has effect on iris problems, the neovascular problems in the iris. And it also depend on the stage. So the treatment depends on the stage of application of these drugs. So if it is enough to give just one-time treatment, or it's needed multiple treatment, it needs multiple treatment. So not just one time. What is your opinion about it?
Oh, yeah, unfortunately, we know that one dose is not going to do anything. It's going to be very ineffective. That's what really that does. Clinical slide I show you, they show that, for example, in a European country where they give, let's say, only 1 or 2 doses in 2 years, there was no benefit. It's clear that you need to give, it's a long-term immunotherapy, and be ideally slowly, since injecting the drug is a major burden to patients, especially if you treat it, inject, intravitreally. So you need, to give, ideally something would last longer. Actually, the slow delivery system, the port, delivery system seems to be is a particularly promising because of that. Because you don't need, you can refill the port every 6 months. So that's to answer your question. You need a continuous delivery, not one administration.
Unfortunately, you're right. There's that's neovascular problems. That's devastating. Yeah. Okay. So we have here other question. If so, you mentioned that VEGF, anti-VEGF substances, they have effect on inflammation, and we know that one of effects of inflammation is formation of new vessels, angiogenesis. So if these anti-VEGF substances will have effect in preventing inflammation, or if they will have effect on the consequences of inflammation?
Well, there is there is many mediators of inflammation. You cannot say that's only VEGF. There is like a TNF, IL-6, IL-6, family. So VEGF is the role of VEGF, I think, is more limited, to angiogenic disorder. Like, there is a variety of inflammatory disease like a rheumatoid arthritis. With anti-VEGF, as be shown for us to have some effect, but clearly TNF, inhibitor have a greater effect. So in inflammatory disease, there are mediators which I think are probably more clinically relevant than VEGF, I believe.
Okay, thank you. So we have the other question. If we're not disturbing you with our
not at all,
lots of questions.
Not at all, please.
Yeah, it's a very great opportunity for us to speak with such a great scientist and ask our questions.
It's a really pleasure to talk with you.
Thank you so much. Yeah, thank you so much. Yeah, we have the other question here. It is about your current research, about your current investigations. That we know you study the effects of neoplasmic angiogenesis, not VEGF dependent angiogenesis, and in particular you study the effect of immune cell, the factors which produced by immune cells, by fibroblast cells, in maintaining the resistance for anti-VEGF substances. So have you any results on that area? Can you?
Well, it's a work in progress, actually. We found, actually, the most recent team of our lab, actually, team which we began a number of years ago, is endothelial cell heterogeneity. There is the response of endothelial cells are different throughout, the body, so they respond in a different way. And so we're very interested in finding factors we can actually can be specific for endothelial cells or some organs. Actually, recently we showed that there is we're looking for a factor which is stimulating selective endothelial cells in the choroid, which is the component in dye, which undergo in macular degeneration. We found a factor, actually was already a known factor, but never identified for this characteristic called leukemia inhibitory factor. And we showed that it's a potent stimulator of endothelial cell growth. We're hoping that giving this factor could be a way to prevent the vessels regression in the geographic atrophy, this kind of condition which is not treated by VEGF inhibitor. We hope that giving this factor we can prevent vessels regression, which could in turn prevent the atrophy of the choroid in the retina. This is one of the areas that we are studying. Other area we try to identify completely novel mechanism of angiogenesis, but this is kind of work in progress. We try to bring to completion.
Amazing, thank you. So the other question is coming that if your research was focused on biological and molecular properties of VEGF, there is the question from students that if the VEGF itself can be used in the disorders which are associated with damage of the vascular wall, with damage of vessels. So not anti-VEGF, but VEGF itself. Can it be used for that reason?
No, this is a very important question. And actually, this topic was called therapeutic angiogenesis. And actually, in the 90s, it was a very hot topic, actually. There is a lots of expectation that VEGF could be used to treat coronary ischemia, limb ischemia. And unfortunately, it led to clinical trial, which none of them was successful. It certainly suggests you need to do much more work to understand how angiogenesis is regulated, therapeutic angiogenesis, because the idea that you give a factor, in a human with extensive atherosclerosis probably didn't work. So I think it's a great idea, but still there was much more fundamental research need to be made, to be done before we can really harness this therapy. But it's a very important idea. There was some clinical trial with the VEGF and other factor like a basic FGF, which I must say, unfortunately, they were not successful.
Thank you, Professor. And the last question is, as we know that science, it requires lots of dedication, patience, and persistence. It's interesting for us, Napoleone Ferrara, he is as a best role model for the science. What you could advise for the future scientists, for young scientists, in maintaining the patience, or have you any other advices? Because you know that the scientific research, it is that we do not get every time the expected results. Even sometimes they are disappointing. And how you are holding a hope in your investigations. So what are the advices that you can give us as other and other future scientists?
Well, it's very difficult to give advice because each case is different. Its situation is different. But what I think worked for me, I think follow your passion. If you follow what you really enjoy doing with terrible research, and that probably will, if you're not interested in, you should do what you really enjoy doing. That will take care of most of the problem, because if you like what you're doing, you will be able to overcome all the problem and become very persistent. This is a key. Try to find something that you really enjoy doing. Medicine and science is such a broad field, etc. I started, as a medical doctor. I didn't particularly enjoy it, to be honest, to take care of patients. I found that some people could do much better job than I did. And I discovered that I enjoy research work in the lab. And that's what probably I did much better as such. So try to find what you really enjoy and apply all your passion and excitement. That's all I can tell you.
Thank you so much. Yeah, as we all know, it is through the scientific discovery that we can achieve the vision for the better life for all. Thank you, Professor, for your very interesting, fascinating lecture. Thank you for being with us today. It was our great pleasure to see you and talk with you. Thank you so much.
Thank you very much. It's been a really great pleasure to meet you and talk with you, and look forward. Maybe sometime I will visit Kazakhstan, which I read. It's a very fascinating country. I've read a little bit of the history, and it's absolutely stunning. Thank you. Have a nice day. It's evening here, but it's a nice day in your city. Take care. Bye.
Yeah, thank you. Thank you from Azerbaijan, from Baku studio, from all of our colleagues. Our medical and biological students, thank you. I am transferring their gratefulness for you as a being a moderator. It was very great pleasure to moderate this meeting, this lecture with you.
Thank you
so much.
Thank you very much.